Today, I just wanted to thank Jim and I wanted to thank Nurse Beth and Alexis for setting everything up. I really appreciate this opportunity and my thoughts go out to all the warriors every single day that I'm working. Today we're gonna get into compounding prescriptions that support CRPS. So oh, there we go. Okay, so disclosures. I am the owner of Precision Compounding Pharmacy, and I'm a preceptor at St. John's University, so I do work for those two affiliates. Overview, what we're going to talk about today, transdermal pain creams that support CRPS, ketamine therapy, and low-dose naltrexone. So before we get into all of that, what we first do need to discuss is a compounding pharmacy. What is a compounding pharmacy? Because compounding pharmacies make all three of those medications. So a compounding pharmacy is more of a traditional pharmacy. So nowadays, when you go into a CVS or a Walgreens and you walk in, all the tablets are made and they're sourced from different countries already. So what a traditional compounding pharmacy does is they pretty much make everything per batch per specific patient. So a patient comes in with a prescription, that specific pharmacist uses powders, they use wetting agents, they use cream bases, and they go ahead and they mix everything together to make a cream or a capsule or ointment or a troche. So it's completely customized. It is not a cookie cutter medication. So they're not using this for thousands, hundreds, millions of people. They're using this, we're making this for one specific person. So all of the formulas that we make aren't approved by the FDA. The specific powders that we're using, the USP and the NF approved micronized powders, they are approved by the FDA. But when we mix them and make them and put them together, they are not approved. They don't go through 7 years of a patent like a specific medication would. And I would consider it a lost art. It's kind of fell off, but people like myself and my great grandfather that did this back in the day, they're gonna bring it back. Um, yeah, and that's another thing. This is something that was very traditional and very regular when you would go to a pharmacy back in, I would say, the 60s and 70s. But it's kind of resurfacing as we're trying to treat the patient as a whole. So the first thing we're going to discuss is transdermal pain creams. This is going to be, so before we get into transdermal pain creams, let's look at oral pain medications and the challenges around it. So or when you look at our oral, there's a lot of side effects that are associated with. First one is gastrointestinal. So a gastrointestinal side effect, you would see something like that from a non-steroidal anti-inflammatory like Advil or Aleve. Renal side effects, you'll see that from more of your Tylenols, your livers, your kidney. You'll see that from Tylenol as well. Cardiovascular, you're going to see from your non-steroidal anti-inflammatories such as your Advil, your Aleve, your diclofenac. Sedation, increase, decrease. You see that by cyclobenzoprene. You see that by baclofen. You also see that by opioids. So opioids can produce sedation, obviously, when they're taken orally. Abuse and addiction. So abuse and addiction is something that is very common with opioids. We're going through an epidemic with pharmacies and providers that are providing opioids. So it's something that we want to be careful and look make sure every patient is using the opioids properly. Non-compliance. I know certain people, and this goes on for, I could say personally, this has happened for me, is when I tried a medication, when I broke my arm or broke my leg or certain different things that I went through in my life, I would try an opioid, and it just didn't like the way it made me feel. I had issues breathing. I felt very lightheaded. So patients can try these medications and tend to wean off of them eventually. Lack of efficacy and kind of some medications don't work the best for pain, I would say, especially some of the non-steroidal anti-inflammatories. So, benefits of transdermal medications. So, I am going to discuss the bad part about transdermal as well. I'm not just going to throw everything that's great about it. So, the customized dosage formulations and drug combinations. When we use a compounded medication, you're looking at using 10 different active ingredients, 5 different, 2 different. So this could be completely customized for that specific patient. Ability to combine multiple medications, less side effects. So when you use a topical pain cream, you're applying it to the affected area, such as the leg or if in CRPS's case, wherever the patient is having that fire feeling at the time. So let's just say it's the toes, they would apply it to the toes. And you're affecting that specific toe or the region that you're applying it to. You're not taking it orally and it's not going through your GI tract and affecting your whole body. So if you apply it specifically to your toe, it's going to affect your toe only. It's going to stay in that transdermal area. So it's a little bit more convenient when you're doing something like that. And the compliance is a little bit better because all you're doing is you're applying to that area that you're having issue in. Decrease abuse potential, obviously, because you're not getting that full effect of the oral medication that's going through the gut. It's less potent for abuse, limited drug-drug interactions. So when you have 2 drugs and you take them orally, they go down the gut, they hit the same receptors. That's when you have an interaction and the patient may not want to stay on a medication for so long if that's going on. First pass metabolism. First pass metabolism is pretty much what I'm discussing about is when a medication goes to the gut. When it goes to the gut, you may, by the time it hits a receptor and goes all the way through the whole body and hits the receptor site of where, let's just use gabapentin as an example, it hits a glutamate molecule. By the time it gets to that molecule, it probably may only be at 50%. So the medication's being broken down for the most part in the gut. When you use something topically, you're not going to get that breakdown effect. And affordable. This is something that I can speak to for my pharmacy and the pharmacy that I'm affiliated with. We try to make these medications as affordable as possible. So you're talking about $39 for 60 grams or $69 for 120. It's worth a try for a patient when it's that affordable. And there are obviously pharmacies all over the country that are doing this. Disadvantage of transdermal pain medications. So patents. We could get a patent on a diclofenac, and that is one specific active ingredient. But getting a patent on 5 different active ingredients, diclofenac, cyclobenzoprene, and lidocaine, all in one preparation is going to be a difficult job for a pharmaceutical company. That's why it lies in the compounder's hands. Lack of literature. There isn't so much literature out there for topical pain. There are for certain ones like ketoprofen and diclofenac, but other things like clonidine and gabapentin, there's not so much research out there. So we do need to try it in patients. Try that first, see if it works. But it's something that we don't have so much literature because pharmaceutical companies seem to not back it in the past. Insurance corruption. So in 2000, and this is the bad part of compounding pharmacy in total and in general, but pain creams kind of got sucked into this whole thing. So what was going on in 2014, and I'm sure some people heard of this if they know about compounding pharmacies, is in 2014, some certain pharmacies out there realized that they could be making a lot of money off of these compounded medications. So what they were doing is they were pretty much putting a bunch of different active ingredients in pain medications. They were charging insurance companies thousands and thousands of dollars, and they were getting reimbursed. And it became very profitable for compounding pharmacies to do that. So after a couple of years, what happens is the insurance companies figures that out and says, we don't want to deal with compounding pharmacies anymore. They're charging us all this money for medications, and it's not it's too much. So insurance companies pretty much ruled out compounding pharmacies after 2014. Co- Pain medications and pain creams got a bad rep after that. But people that are charging cash prices and making it affordable, kind of changing it for patients that will do better with a topical pain cream. Efficacy. So efficacy, like I stated earlier, it's always good to try a topical pain cream. It may not work for certain people, but certain people, it works great for breakthrough if they're having a fire breakout in their toes or their fingers or their legs, and they need something to kind of stop the breakthrough. It works great for something like that. And like I said, some patients it may not work for, but it's definitely worth a try. Okay, this looks like a lot. There's a lot of active ingredients here. I want to kind of breeze through them very slowly and go through. These are the most important active ingredients when we're talking about a compounded pain solution. So if you're going to a compounding pharmacy, you're going to see one of these active ingredients in your medication. It's probably going to be hard to say or spell or pronounce, but you'll see a couple of these medications in your specific pain cream. First one is Acyclovir. Acyclovir is an antiviral. Works really good for shingles. For CRPS, we don't see it too much, so I'm kind of going to skip over that one. Amantadine. Amantadine works by hitting the Nmda receptor. Works very similar to ketamine, so doctors seem to prescribe this if they don't want to use a controlled substance, but they do want something to work very similar as the ketamine. So it hits the Nmda receptor, blocks glutamate from hitting that receptor. So it works really good for nerve pain. Used at 8% and very good absorption. So I really like amantadine. Amitriptyline is a tricyclic antidepressant. It was used orally, and pretty much what they figured out is it's really good for nerve pain. The structure of amantadine is very similar to cyclobenzoprene, so it works when it's applied topically. It works by kind of working as a muscle relaxer, and it's used as 2% concentrations. This medication is specifically used for vaginal nerve pain, but it actually works really good topically as well. Baclofen. Baclofen is a muscle relaxer. It's used at 2%. It hits the GABA receptor. It can make patients very sleepy, but when it's used topically, we really don't see those side effects at all. Bupivacaine. Bupivacaine sounds like lidocaine because it is very similar to lidocaine. It is a sodium channel blocker that causes numbing in the area. And when CRPS patients are going through pain, a numbing agent can work very good for that patient. This one specifically, bupivacaine, works a lot more potent than lidocaine. So it's something that we add into the pain creams to kind of give it a little boost. Camphor. Camphor is very commonly known commercially as icy hot. So when you apply it, you would get the cooling effect of a medication. That's known as a counter irritant. So kind of when you hit one side of your leg and the other side is in pain, you're kind of distracting your body from that pain sensation. So camphor is a good example of that. It causes a cooling sensation and actually can stop substance P on a scientific level. So it's a really good one, camphor. Capsaicin. Capsaicin is red hot chili pepper, causes a inflammation and a nice hot feeling. Works as a counter irritant as well, but this is something that can really help people. It helps really good in certain combinations with diclofenac and with cyclobenzoprene. But some people really like it. They like that burning sensation. Some people don't. I know for CRPS patients, they may not like that burning sensation, but it's good to give it a try. Clonidine. This one's actually very it's very interesting. It was used as a hypertension medication, and they used it in a patch formulation for hypertension. But what patients were realizing is that when they applied it to their skin, they were actually having better results with their pain symptoms. So compounding pharmacists figured this out, and they started working with these patches, and then they were able to put it in pain cream. So we use this at a 0.01% preparation, and it works really good in combination with gabapentin, ketamine for nerve pain. The next one, cyclobenzoprene. Cyclobenzoprene is a muscle relaxer, works at the GABA receptor. Very similar, like I said earlier, to amitriptyline, causes relaxation in the area, and it's really good for muscles and tightening and stiffness. Really good for nerve pain as well. Used at concentrations of 2%. Diclofenac. This is the most well-known cream for pain, inflammation that we've seen. It's available as Voltaren over the counter at 1%. When we compound it, we're using it at 5%. Just for people that don't know or are unaware, this is very similar to ibuprofen, but it's in a topical formulation. Its absorption is great. It's very sticky. The molecule is very sticky itself, but its absorption is great, and it works good when it's being used to affected areas. Dimethyl sulfoxide, DMSO. This is not so much an active ingredient, but it works to increase the absorption of all these different pain active ingredients. It was used back in the day to increase medications into horses. When they were using horses to race, they would actually put a powder of medication on the horse and add DMSO liquid to increase and enhance that absorption. Eucalyptus works very similar to camphor. Florbiprofen. When I mentioned earlier 2014, this florbiprofen is a perfect example of 2014 and the corruption that went on in compounding pharmacy. Florbiprofen does not work at all. It is just used to bill insurance. So if you're getting this from one of your compounding pharmacies and they're taking insurance right now, be very careful. You should try to ask them for something like diclofenac or ketoprofen. Gabapentin. Gabapentin works by stopping glutamate, or it's a glutamate antagonist. What glutamate does, and we'll learn about this more when we talk about ketamine in a little bit. What glutamate does is it hits the Nmda receptor, and that kind of causes the brain to fire. So this will actually stop that from happening, and it works great in pain creams. The absorption's great. It's used at 5%. You don't see side effects like sleepiness, tiredness, edema, water buildup. You won't see that. Next one is ketamine. I'm going to push this to the side for now because we are going to get to that after the presentation. Ketoprofen. Ketoprofen is kind of overshadowed by diclofenac. It works the same. It's a non-steroidal anti-inflammatory. Its absorption is fantastic. I actually like it better than diclofenac. So we use that at 10%. It's less sticky. The absorption's fantastic. A lot of the professional baseball teams actually use this one. The next one is ketorolac. Ketorolac is known as Toradol. Talk about professional sports players. When I think of the Red Sox last World Series, I think of ketorolac because they requested this specially from our pharmacy. We made it, and they went on to win the World Series. I don't know if it was because of the ketorolac, but I like to think of that in my mind. This is a non-steroidal anti-inflammatory. It is super potent, and you can't be on it for more than 5 days. But it works really good if someone's having super inflammation. Lidocaine. Lidocaine works sodium channel blocker, numbing agent. Magnesium. Magnesium is awesome. Its absorption as a topical preparation, it goes through the skin, works intracellularly, and causes relaxation of that specific cell. Now, this is actually available as a supplement. I like to recommend it from a company called Vintage Labs Collection, and the formula is called Gentle Gel. But you can get this from regular pharmacies, but I would definitely look into that. It is great for relaxation, and it can be used about 3 to 4 times a day. Menthol works just like camphor, works just like eucalyptus. It's a counter irritant. Methyl salicylate is the same thing as well, counter irritant. Nifedipine and phentoxyphylline. Those are blood pressure agents. They're used for blood pressure. But what they do is they cause vasodilation and they let more blood into the area for healing, which is great if you want to heal areas. For CRPS, it's probably not the best thing because we're not trying to heal an area. Tetracaine works just like lidocaine and bupivacaine, and verapamil works just like nifedipine and phentoxyphylline. So these are your active ingredients that you'll see on pain creams. If you have any questions about these, obviously later in the presentation you can ask, or you can email me and I can send you information on each individual one. Bases.
Hello. Chris, are you taking questions now? We're going on. Okay.
Yeah, we'll do that at the end. Is that okay?
Well, that's perfect.
Okay. Bases. So this is where we're actually putting the active ingredient into. So a transdermal pain cream will have the powder, and we'll put that into a base. The specific one that we use and has the best absorption is Transdermal Cream Base. This one drives it right through the skin. We have preservative-free bases, and most compounding pharmacies have these as well. And also VersaPro. VersaPro is hypoallergenic and it's parabens-free. It's really good for the skin. All right, so we are done with pain creams. We're going to move on to low-dose naltrexone. Low-dose naltrexone, I like to call it the ATV, the all-terrain vehicle. It can be used for 50 different conditions, but today we're going to talk about one. Okay, history. I'm going to skip this slide. If anyone has any questions about the history of low-dose naltrexone, they can email me. This is the most important part about this whole history slide is Dr. Bahari. Dr. Bahari in 1985 in New York City. I want to give a big shout out to New York City. What he did was he did a lot of research on the opioid receptor and low-dose naltrexone, and he was the pioneer. So I just want to say a nice thank you for Dr. Bahari, and we will continue to discuss his legacy. Okay, before we look at low-dose naltrexone and we look at how it works, I would like to look at how an opioid works. So pretty much all you have to know is that the hypothalamus produces corticotropin-releasing hormone. That goes on and that hits POMC, which is pro-opioid melanocortin, and that goes on to produce endorphins. Endorphins are produced in your body. They're a feel-good hormone, and they alleviate your body from pain, and this is how they do it. So what they do is pretty much an endorphin goes over to it goes over a neuron from one neuron to another, and it will go from a presynaptic cleft to the postsynaptic cleft. And when it goes ahead and it does that, it hits the receptor, and your body stops substance P from going over to another receptor. So the endorphin goes to a receptor, acts on that receptor, and blocks substance P. Substance P is how your body produces pain. So endorphins in your body for pain is a good thing. We want endorphins. Okay, so now before I discuss how low-dose naltrexone works, I want to discuss naltrexone itself because we've seen this available. It's available at 50 milligrams. It's an opioid antagonist. So if someone's overdosing on an opioid or they're overdosing on alcohol, people will use naltrexone 50 milligrams full strength because it's going to fully block the receptor, the opioid receptor. It has no euphoric effect. It's used in alcoholism. It was used for opioid addicts in 1984. It kind of fell out of favor because now we're using something called Narcan that you'll see used if someone's overdosing. It will go straight through their nostrils, and they'll kind of sit the patient up and inject it on site of a specific trauma. Naltrexone, traditionally, is used at doses 50 milligrams to 300. And it is going to, at that dose, fully block the receptor. We're not going to talk about that. We're not going to use that. We're talking about 4 or 5 milligrams, 3 milligrams, 1 milligram in that range. So how does low-dose naltrexone work specifically? We're going to look at low-dose naltrexone as 2 different molecules. It has something called chirality. So one side of low-dose naltrexone works, that's the dextro side, works a little bit different than the levo side. That's another side of low-dose naltrexone. Naltrexone can hit the receptor in 2 different ways, the levo or dextro. So the way it works in levo, I'll discuss that one first, is that's your traditional endorphin way of low-dose naltrexone working. So what it's going to do is low-dose naltrexone is going to go through your body. It's going to hit the opioid receptor only slightly. So not at 50 milligrams, you're going to hit it at a 1 milligram or a 2 milligram, which is a very small amount of naltrexone. That is going to cause the receptor to be like, something's going on. This isn't right. And it's going to cause your body to have a negative feedback mechanism that's going to release tons of endorphins, more endorphins than your body would ever produce. And those are natural endorphins. That natural endorphin increase is going to work for pain. And also, why you hear of naltrexone being used for autoimmune conditions, for immunity in general, is your T cells in your body actually have opioid receptors on them. So when your T cells are traveling around and you have more endorphins from low-dose naltrexone producing more endorphins, your endorphins are going to be upregulated, which is going to therefore upregulate T cells because your T cell has an opioid receptor, and that's going to produce your immune system to be modulated and work a little bit better. The other side of naltrexone, and I like to call that kind of the endorphin side of naltrexone. The other side of naltrexone is the dextrose side. So that way is the TLR receptor. TLR receptor is something in your body that causes chronic inflammation. When naltrexone works, the way low-dose naltrexone works is it hits the TLR receptor and antagonizes it. Pretty much, it blocks that receptor and it decreases inflammation. So you have this one little drug that's working for pain in 2 different areas of the body, at your endorphins and your TLR. So that's why it's such a great and powerful medication. Formulations of low-dose naltrexone, obviously, because usually it's 50 milligrams, and we're compounding it and we're using it, we're making it at a lower dose, 0.5, 1, 1.5, 2, 2.5, 3. It needs to be made at a compounding pharmacy. And usually compounding pharmacies are making tablets. Tablets are affordable. They can be scored for titration reasons. Capsules. Capsules are used if a patient's having an issue with a filler, or they want a vegetable capsule. They want something more natural. We can use vitamin C fillers. There can be ginseng fillers. There could be lactobacillus fillers. So that's an example of a capsule. Suspensions, and that's just an oral liquid. People like suspensions because it's so easy to titrate up or down on doses. So one day you can wake up and be like, I want to just take a little bit of that suspension, or you could take a little bit more, and it's very, very easy to do that. Also, the flavoring is different. Uh, Blister pack titration is starting a patient at a lower dose and increasing to a higher dose. And usually, low dose naltrexone, you need to do that. You need to titrate a patient on because of the side effects, and we'll discuss that in a second. Troche is sublingual. Usually we use that under the tongue is because some patients have malabsorption and their body breaks down naltrexone poorly in the gut. Transdermal creams for low dose naltrexone, it could work. I don't like to use it because I don't think it works as best as the others. Drug interactions. So looking at drug interactions, we are hitting the opioid receptor, so any patient that's taking opioids, we want to use this very cautiously. A lot of physicians that I work with, they use it with opioids. They just start patients a lot lower. Corticosteroids at very high doses, so 20 milligrams of prednisone would be an example. Side effects. Now, this is why we're starting patients very slow and slowly working them up because we have the option of doing this and we're using a compounding pharmacy. This is the best way to do it. So we want to start them at about 0.5 or 1 milligram and slowly work them up because of nightmares or headaches or stomach cramps or diarrhea. We want to make sure that the patient is doing better and not having so many of those side effects. Then we could slowly bring them up to the goal and where Dr. Bahari did some of his best studying, and that's at 3 milligrams or 4.5. So side effects. Nightmares, very common. And usually some of these could be transient. So the patient will have it for maybe 2 weeks and it will go away. So nightmares, insomnia, vivid dreams. It's funny because sometimes patients sleep better with low dose naltrexone, or they have bad nightmares, and like I said, that could be transient. So nightmares, insomnia, vivid dreams. We have stomach cramps, GI side effects, just like any other medication out there. We're seeing GI side effects, headaches. It can affect the thyroid. It's actually used for Hashimoto. So if a patient's on Synthroid, we want to be careful and make sure that their provider is aware that it could change their dose. Their chills, flu-like symptoms, and that's usually when doctors are using it for chronic fatigue, agitation, dizziness, elevated liver enzymes. That's very rare. I just wanted to include that, but that's very rare. And renal dysfunction, very rare as well. Contraindications, surgery, obviously, we want to discontinue 2 days before, acute hepatitis, and liver failure. All right, low dose naltrexone, we're all done with that. Questions we'll get to at the end. Ketamine. So this is the new wave of medicine. I like to call it the introduction into psychedelic medicine. It is the door into psychedelic medicine as we know it. It is being used very heavily right now, and it is working very well for depression and anxiety. It's working great for CRPS as well. So all of the ketamine physicians that I work with, most of them have a CRPS program, and the dosing schedule is a lot different from anxiety and depression. So the introduction here is pretty much ketamine started out in the 70s. It came out as an anesthetic and it was used for surgery. Obviously, people got a hold of this, and just like any good thing out there is they started abusing it. So it was abused in the 70s. People started grabbing and getting from hospitals the reconstituted powder for injections, and they would take that powder and they would snort it, or they would most likely snort it. So that would give them an outer body experience. So it was abused very early on. After that, it kind of fell out of favor and it was getting more known as a street drug. After that, it became known as a horse tranquilizer, and that's just a big rumor. I've spoke to many physicians out there, and it did get a bad rep for that. It is used for animals, but as a horse tranquilizer, that's false information. It is used as a sedative hypnotic, and it is a Schedule 3, so it's not a narcotic Schedule 2, but it is a Schedule 3. In New York State, it can have refills. In other states, it could as well. And then now, in the timeline, the reason it got so popular is because a drug came out called Spravato, and that's a commercially available ketamine form that's being used for depression. So now it's kind of resurfacing, and also there's been physicians for years and years that have been doing a lot of research on ketamine and how it works at the NMDA receptor. How does ketamine work? So the big one here, I could talk about all these in detail, but the big one here we're looking at is the top, the NMDA receptor, and I spoke about this earlier with gabapentin. So ketamine blocks the NMDA receptor. So that receptor is on the brain, and it causes excitatory and increase of action at the glial cells. So what that does is that kind of causes chaos in the brain and pain. So when you have a medication that kind of works as a psychedelic and blocks that receptor, that NMDA receptor, you don't have glutamate penetrating it all day. So it works really, really well, and it does a good job at blocking that receptor. Dendrite and synapse growth. It is an 8 to 10 hour process. So after patients use ketamine, it does help the cells in your brain grow. There has been research that has been conducted, and there's going to be a lot more coming out. Weak monoamine reductase inhibitor. So that's an antidepressant receptor, and it does hit that receptor as well. It hits the opioid receptor very weakly, and it hits estrogen, nicotinic receptors as well. But I really like to just focus on the NMDA receptor as that's where it's having most of its response. Indications. What's it being used for? It's being used for pain, CRPS. It's being used for depression, anxiety. And now we're seeing more research in schizophrenia, bipolar. We'll have more information on that in years to come. But right now it is approved as ketamine, Spravato, and depression, anxiety, and pain. It's being used in infusions and so on and so forth. Availability, like I mentioned earlier, Spravato. That's the available medication that is commercially available for anxiety and depression. And it is available as an anesthetic in 100 milligram per ml injections. It also is available at ketamine infusion sites, and they usually do infusions on patients once a week for 6 weeks, and they'll assess after that. So usually, and I was lucky enough to actually go in with a patient to one of my friends who's a physician, and I got to witness a patient that was going under a ketamine infusion. And usually it is quite nice to witness, so I was able to kind of view it from the pharmaceutical side and the therapeutic side. So the patient gets the ketamine infusion. Usually they'll be hooked up to a blood pressure machine because it could move blood pressure up and down. They'll usually be in comfortable clothes, relaxing. And at that point, when they do the infusion, they could have dissociation. That's the out-of-body experience. And the patient just relaxes. They could fall asleep, but it's a procedure an infusion that lasts for a couple of hours. So it was nice to witness that. If anyone does have questions about that, I could answer that. Formulations. So why am I talking about this as a compounding pharmacist? Because it isn't available as any other form right now. So ketamine is only available as an injection. There is absorption. So we can do this in a transdermal pain cream, which is really good at 15%, works fantastic. It gets absorbed, it hits that Nmda receptor injection, but that's most of pharmaceutical medication and physicians that are doing they're doing injections and infusions at their office. Troches, troches, whatever you, however you would like to pronounce it. This is a sublingual tablet under the tongue or going buccally in the inner cheek. This is probably the most common way that we see ketamine in our compounding pharmacy, usually done from 10 milligrams all the way up to 200 milligrams. It's a lozenge, it could be flavored, comes in about 50 different flavors. It goes into the buccal route, and it goes from that buccal route, inner cheek, straight into the bloodstream and works, I would say, 60% of the way the injection's working, bioavailability. Next one, rapidly dissolving tablets. I would call this the second generation troche. It's a little bit more, it's a little bit newer. They absorb a lot quicker. They're hard tablets where the troche is a square and it's more of a gel. The rapidly dissolving tablet is a physical hard tablet. You put it under your tongue and it dissolves, I would say, about 15 minutes, where the troche may take a half an hour. Capsules, there's not so much research with capsules because once it goes down the gut, it's pretty broken down. It breaks down very heavily. Suspensions going down the gut wouldn't suggest that route. Nasal spray. Nasal spray goes through the nose and it hits the veins and the little arteries that you have in your nasal passageway, goes straight through and goes to the central nervous system. So this way is very popular. It's also very popular in a compounding pharmacy because of Spravato kind of gave it that name. But yeah, this is very common. Physicians are using this part of their ketamine protocols. Suppositories, not so common, but there is some absorption and it is used in the suppository. Okay, operating heavy machinery, obviously not the best thing to do while using ketamine. Using alcohol could make intoxication a lot worse, so we don't recommend it. Side effects of ketamine. So, feeling drowsiness or intoxication is one of them. The other one is the dissociation. That's kind of having an outer body experience. And you do not have to have this experience for the ketamine to be working. It is something that is kind of hyped up by the media that if you are taking ketamine, you need to dissociate to have effect. It is not like that. You can just take it and not dissociate. I would call dissociation more of a side effect. Mood swings, and patients tend to dissociate a little bit more when they're using an injection. Mood swings is definitely a possibility. Vivid dreams or hallucinations, it is affecting the central nervous system. And like I said earlier, patients may do the blood pressure cuff when they're getting the infusion, and their blood pressure may go up or down, so it's important to monitor that. Decreased blood pressure as well. Drug interactions are listed right over here, and usually I would say that the reason these drugs interact is because they hit the same receptors as ketamine. So if you're hitting the same receptors, one of the medications can fall off. The last thing I wanted to mention, pretty much to wrap up, is supplementation. Supplementation is very common with compounding pharmacies. You'll see CBDs, you'll see CBD creams, CBD tinctures. The one that I mentioned before, magnesium gel, magnesium glycinate orally goes straight into the central nervous system. Curcumin used very commonly. So I like to mention this always when I'm discussing with a CRPS patient. I always like to go with a professional grade brand because you know that they're testing. The brand that I like is a company called Vintage Labs. Their website is Vintage Labs Collection if anyone wants to go check them out. references, you have two solid references right here. And then thank you very much. That is my email. That is the extension at the store if anyone is willing to call. Questions, if we have time.
Christian, can you hear me?
Yes.
Okay, I do have the questions. Think I'll start with the ones that we saw for the ketamine. There's a lot of questions about the ketamine and interaction with the opiates, and being told that you can't have aren't have them at the same time. So, can you speak a little about that relationship?
Yeah, of course. So obviously we see this very often that a patient is maybe been taking an opioid for a very long time and they feel like maybe it's not working so great and they do want to get off of it. Ketamine can be taken with an opioid. It does hit a complete different receptor. It may hit the opioid receptor. So this is really going to come down to the physician and what their beliefs are. Personally, I think it's okay. I think it's okay if a patient starts at a very, very low ketamine dose and they are monitored every single day by their care provider. It's going to depend on their care provider. Like I said, some doctors that I deal with, they're okay with it. Some doctors never do it. But and if a doctor is going to do it, they should really monitor very, very closely.
Okay. I also forgot to say thank you for the presentation. It was really excellent. We all appreciate it. My next question is, if you have POTS and CRPS, what it's Clonidine, so you would not take Clonidine, or you could? What do you what's the recommendation there?
So you could, you definitely could. That's something that was used. It's used for nerve pain. So all it really does when you're using it topically is it kind of intertwines it and moves your neuropeptides around and relieves pain in the area where you're applying it. So I do think it's a really good one for nerve pain, and especially if someone's having CRPS associated nerve pain in a specific area, it's a really good one for a patient with CRPS.
Thank you. There's another question. If you've had CRPS for over 5 years, is ketamine still a consideration, or at that point you've had it too long and you can't be helped?
Definitely still a consideration.
Okay.
100%. And there's physicians out there that are very, very well educated using ketamine for CRPS.
Thank you. What else? I think that is, we're getting a lot of, I think the other questions people can email you thank you very much for that.
And I will answer all the questions. It may take me some time, obviously, but whatever question, I will get to it eventually.
Okay. Beth, I was going to ask you, she had a couple of questions about troches. Let me see if I could just give me a second. Does ketamine nasal spray work faster than troches? How often can nasal spray of ketamine be used?
So nasal spray well, first I'll tell you that the nasal spray does work quicker. It has a quicker onset than a troche. They're very, very close, but nasal spray I don't think they're so close that I don't think a patient would even recognize the difference, but it does have a quicker onset. Part two to that question, what was it?
The part two was how often, or about the nasals, how often can the nasal spray of ketamine be used?
Okay. So that's really going to depend on condition. So obviously we're not talking about anxiety or depression here, but that's going to be once a week most of the time. When it comes down to CRPS, we're seeing very commonly that CRPS is anywhere from 1 troche to 4 troches a day, dose dependent The troche will be 10 milligrams to 150 in that range, but it is for CRPS, it's most likely going to be used every single day.
And everybody's asking about the compounded, using compounded pharmacy and insurance. So,
Yes, okay. That's a terrific question. So my pharmacy doesn't take insurance. There are pharmacies out there that do. I encourage patients to try it. But the reason we don't take insurance, I'm just using our pharmacy as an example, just so people understand why we don't take insurance, is because insurance companies really never end up paying for these formulations. So what we do is we give affordable care prices, like LDN usually for a 3-month supply is like $40. Ketamine for a month supply is anywhere from 60 to 75. That's an affordable care price. Compounding pharmacies that do take insurance, there's a possibility it will go through. I would say maybe 20 to 30. So I encourage patients to try it. It may be worth it. But a lot of compounding pharmacies don't take insurance because they just don't pay.
thank you.
Which stinks. It stinks.
Alexis, please jump in now and wrap up for me.
No problem. I just hopped on over. See what I did there from our other session. I'm seeing everyone in the chat. So thank you all for all of these amazing questions. And of course, we have been recording, so we will make sure that we get this over to you all. But thank you so much, Christian, for joining us this evening. Like I said, there's so many people in the chat asking questions, so I definitely know that this was an informative session. So thank you so much.
Yeah, no, thank you. And I thought your presentation was great, and the slides very thorough. And I think people heard about some treatments and choices that they didn't know about before, which is.
Thank you. I appreciate everyone for having me. I encourage the Warriors to give it all you got and keep on going and keep on fighting. Thank you, obviously, to Nurse Beth. She's phenomenal, and Jim. I love both of them. Thank you, guys.
Definitely. But of course, even though this presentation is over, the night is still young. So our networking session, our expo is also still open. We have a booth with Brian Pope, who's going to discuss, CRPS and the law this evening. Then we also have a booth with Fight the Flame. We have some RSDSA info booth. I know Jerry's going to man that booth this evening. So definitely go ahead and hop over to the expo. And also, like I said, check out the networking. We will also have 2 more presentations tomorrow. So you can speak to Brian tonight, ask a few of your questions regarding CRPS and the law, but he is going to also discuss that tomorrow on his presentation. And we're also going to have an amazing presentation focused on advocacy. So we hope that you all can come back tomorrow evening. Be sure to send a link to anyone that may have missed out. We definitely want to make sure that we see you all for the final night.
Oh, yes. I wanted to push a couple of things. The auction is going until tomorrow night, and then we'll close. We do have some things, and I will be adding some RSDSA merchandise tomorrow to one more item. And, November 1st, Color the World Orange, and November is CRPS Awareness Month. So please keep checking in as we'll have things through the month.
Good. See you all over in the expo.